Thanks so much, Jonathan. I want to start by thanking you and CFIT and Hopkins for tremendous leadership in this area. You know, one of the most amazing parts of the different positions that I've had is having such an amazing institution like the School of Public Health here in Baltimore, and the incredible openness and partnership on so many different things, and particularly with this field of population health and health IT, which is really just emerging. It's just terrific to have such an interesting and effective group in town. I also want to thank Farzad. That was a great talk. It was sort of the trade-off is having to follow Farzad is not such a fun thing to do. On the other hand, it's such a great talk and inspiring to kind of to get me going. I think I'm going to try to relate back to what Farzad said in a few different areas, and I'll probably be more on the public health side than the clinical medicine side as I talk about it. But I'll do my best to make the connections, and then I will see what you want to talk about. So I want to start about 2 years ago in my job as the state health secretary, where we run the Medicaid program. It's about an $8 billion program. We have a number of managed care organizations in the program, and they each have their own service areas. The leadership of one of the managed care organizations came in to see me, and they brought their lobbyist, and they sat down with me in our conference room, and they went through this whole presentation about why they wanted to expand the number of counties that they work in Maryland. And it was a lot about their business strategy. And I let them do the presentation, and at the end I just said, I'm completely convinced why you want to expand. But why should I want you to expand as the health secretary? It's like complete silence on that one. Absolutely did not get the question. Totally blank look on their face. So I tried again. And I was like, I'm the health secretary, I'm interested in public health, I'm interested in the health of the populations in those counties. What do you guys do? What's going to be helpful to their health? Nothing. I mean, just like complete, nothing. So it's starting to get a little awkward. I'm like throwing out ideas, is there some program you have, anything. Till finally, one of the leaders said, and I am not making this up, that at their enrollment events, they have a dancing animal that the kids like. I won't tell you which dancing animal, because it might identify the managed care organization, but that was it. That was their concept of population health. And I left there just totally perplexed. Like, why would they think for their business, my job as the health secretary or health commissioner of the city is for the health of the population. That's the language that I speak. I don't care if it's in their business strategy. I want to know what it really matters to people. So then fast forward another year, and I had a meeting with a senior hospital executive in Maryland who was really excited because he wanted to tell me about their population health strategy. And I was like, great, population health. Which communities are you focused on, and which are the health risks you're going to tackle first? Like, total blank stare. Didn't understand what I was saying. He was talking, I was talking. It was like complete confusion. I did not understand what he was doing until finally, it was a very, very awkward and memorable conversation. I realized that by population health, he was talking about possibly the hospital system offering an insurance product. That was their population health strategy. That's what he meant. I meant, public health in the way that I've been doing it. So I think one of the questions that Jonathan asked me to address is, what do we mean by population health? And I would say, I saw your definition. From my vantage point, having worked in local and state government, population health is the health of a population, not just their insurance status, the health. The goal being to advance the health of a group of individuals that is not pre-selected. You can't just pick the people. Now, the group can be a different kind of group. It could be a population that is enrolled. You're not picking them. It could be people who go to a certain house of worship. It could be people who are attend football games. There's a population, but you have to take all of them. You can't pick and choose. But having said that, I think one of the major points I would make from my vantage point is that not all populations are created equal for the purpose of thinking about population health. And in particular, I like, and I'm going to try to make the case to you, that populations that you draw on a map with lines are really, really important populations for the concept of population health. And the reason is, I believe that analyzing health by geography allows for greater stability in measurement, less gamesmanship, like you can, people can do different things to affect their populations in other ways, but very rarely if it's truly a geographic-based population. And most importantly, more opportunities for intervention. You have a whole different set of tools, an entire other field of public health, thinking, research, everything when you're doing things on a geographic basis for public health. In a clinical population, and I appreciated this part of Farzad's talk, most of the interventions first start with clinical and clinical quality and all the things he talked about redoing, and I'm in complete agreement with everything he said there. Outside that clinical space, you start talking about things like chronic disease management and things that are clinically based, that reach out to the patient. If your population is the patients that come to your clinic or the patients in your insurance product, you're thinking about, okay, let's find the ones who have this disease, and let's figure out how to reach out to them. Let's do things from the central clinical part. And some of those efforts are extremely important. I'm somewhat skeptical of other things. People talk about population health management, and sometimes they use the phrase telephonic case management, which is a phrase I would ban from the lexicon. I think it sounds too much like stalking. You're like calling people, have you gone to this appointment? I'm not really aware of it, a lot of information, but there's a huge amount of telephonic case management, and people think like, oh, I've got to manage chronic disease, I'm going to find them and I'm going to do telephonic case management, and then maybe that evolves to different types of case management. But those are the major tools I think that a clinical system or a clinical version of population health has. But when you're talking about a geographic population, there's a lot of more tools you can bring. And I'll give an example. When I was a city health commissioner, one day I did the worst part of the job as city health commissioner, I had some random jobs. I was the chair of the board of the animal shelter. I was, just all sorts of strange things. But the worst job was I was the chair of the child fatality review. Every unexplained death of a child, we did a comprehensive review of the case. I'm a pediatrician. It's the most miserable meeting. And one year, I did a press release based on those reviews. 20 babies in the city of Baltimore died in unsafe sleep positions last year. And nobody covered it, okay? It just went under the radar. No matter what, I called reporters, it was just like, well, that's kind of what happens. We tried everything, and I'm gonna do it's similar to Farzad. We had a little onesie, that said the ABCs of safe sleep, alone, on your back, in the crib. And if the child was put on their stomach, it said, turn me over if I'm sleeping, We gave that to like every baby born, okay? I sent letters every time there was a baby. I wrote a letter to the delivery unit, and I said, you had a baby die of unsafe sleep. I just want you to know. And they wrote me back, we changed our education, we're drilling it into the nurses again, and we had all this information, and it really didn't matter that much. As I was winding down, or about to move to FDA, we'd done a big database, evidence-based review of our infant mortality issues and the racial disparities in infant mortality in Baltimore. And we found unsafe sleep was a huge contributor and the most preventable. And we actually went to Care First, and we got a major grant. And I got it set up, but then it was all implemented after I left. And the major focus was on community-based interventions around safe sleep. There was a terrific video that was done by the team at Hopkins that does a lot of health education work, where they found parents who lost their kids looking right in the camera, saying, I didn't realize this is, if there's one thing I could tell you, just put the baby alone on their back. It could make literally the difference. I'll never be able to see my child again, but you'll be able to see yours. They played it all over the city, in the jury rooms and the social services, and we've seen an enormous reduction in sleep-related deaths, a significant decline in infant mortality related to that. And we see from surveys that people are changing their behavior. There's a lot of other work that was going on in that. But if you think about that, that's not something that, it's related, but it's not the clinical model of how you can make change. Just one other quick thing, in infant mortality, there is a lot of work that had been done on home visiting. And home visiting, the home visitors would always give great results for their patients on their infant mortality or low birth weight scores, and yet the city wasn't getting any better. And that's because if people slam the door in their face, they didn't enroll them in the program. But if you do a geographic-based responsibility, you don't miss people. That's why I think that it's very important to think about geography related to this. So with this perspective on population health that I have, I'm going to talk about a few things that I think are going right and some of the challenges. That was partly what I was asked to do. So the first thing that I think is going right is that public health data increasingly really is becoming more local and more actionable in all sorts of ways. When I was a city health commissioner, we worked with Bloomberg, and we just using students, we did community-based life expectancy reports down to literally the community in Baltimore, and a whole health report for that, sort of a little bit ahead of its time. It wasn't like an automatic online system. This was like 2006 or something. And we reported a greater than 20-year life expectancy difference across like a mile in the city of Baltimore based on the neighborhood. And that got a huge amount of attention, and for the first time, I would go to community meetings as a member of the mayor's cabinet. Mayor Dixon would sit up on a nice stool, and all of us would be sitting behind her, and we get whatever questions from the community would come. And most of the time, I either got asked a rat question or I got asked no questions. And I would get texts from the police commissioner, Sharfstein pitches another shutout. You know, after we released those reports and handed them out, people were asking about stuff like that, and it was incredibly valuable. In Maryland, I just want to show you, this is one website which we called it Around the State Health Improvement Process, where we have picked 39 health measures through a public process. Let's see if this works. These are the different measures. For each measure, not only at the state level can you see it by county, can you see it by race, ethnicity, can you see the history. This is the teen birth rate. But then each county has its own website to look at its measures, and we've aligned, there are different public-private planning coalitions in 17 regions that correspond to this, so people can go online, see all the data for their region. There are all sorts of things going on locally. The hospitals put in the startup funding for that, and I'll get more to that later. But it's dhmh.maryland.gov/SHIP. So it's all online and very popular here. So that's number one. Number two, our health information exchange is, and health information exchange can align with geographic population. So you have public health data coming in with geographic populations and HIE. And in Maryland, we have a system called CRISP. I think there may be someone from CRISP here. Is that true? Maybe not. I saw them last night. It's called Chesapeake Regional Information System for our patients, and their logo is a crab. And people say, why is it the crab? And I said I thought it was because if you had crabs and you went to a different hospital ER, they can look up the diagnosis in the computer. But they said no, it was because of the Chesapeake part. Okay. So CRISP in Maryland is now a verb. It is, all doctors can get access to it. They can see reports from every hospital, every ER, almost all the labs, almost all the radiology. And it's a verb. People say, like, have you crisped your patient yet? And my wife, who's an addiction medicine specialist, and usually is full of constructive criticism for the health department and other things that I do, she occasionally will get called in the middle of the night about a patient, and she'll get back in bed, and she almost always says, thank God for CRISP. So you can figure out what's actually going on with her patients, even in the middle of the night. There's a lot that CRISP does for clinicians, and I'm not going to talk about that so much, except to say that one of the things CRISP does is any primary care doctor in the state can upload their list of patients and get immediate secure notifications when the patient gets to the ER, and there are like 10,000 of those notifications sent a day. And we use that in a lot of different ways. We are using it as a common platform. Governor's invested a lot in it. When we started doing this, we work with them to change their governance structure. Our prescription drug monitoring program is within CRISP. We are looking, hopefully, to make our immunization records available within CRISP. So it's become a great clinical tool, but it also has unbelievable implications for better geographic population health management. And through, we have been investing in this through the state innovation model, and I'm just gonna try to show you some slides if you can see. We basically can get real-time hospital utilization data. We're linking into our hospital payment system so we can get payment and detailed diagnosis data at the same time. We can basically do real-time maps to any level of geography. This is hospital utilization by census tract in Prince George's County. But we can even go, to whatever level. This is example data in West Baltimore. It's just a terrific tool. So you're seeing the ability to use these shared resources for geographic population health. The third thing that, and I think you could, I'll leave this up here. The third thing is that, to Farzad's point, payment incentives are increasingly, at least in Maryland, aligning with geographic populations. And let me just give you a brief overview of this. So I think of payment incentives going back to when I was pretty new in this job, and I was invited to meet with the Baltimore Ecumenical Council. And even when I was health commissioner, I never had met with them before. They wanted to talk about the Affordable Care Act. So I was running around Baltimore. I was late for the Baltimore Ecumenical Council. And I showed up, and I ran into the room, and there were like 16 ministers in very severe, formal, ministerial, attire, all looking aggravated at me. And I apologized profusely and very stony face, And they asked me a bunch of questions about the Affordable Care Act. And then finally they said, Dr. Sharfstein, why is healthcare so expensive? And the whole thing was, I was just a little bit unnerved by it because I'm used to getting like some reaction as I'm talking. And I said, well, there's obesity and there's tobacco use. And I said, but the truth is cardiovascular risk factors are going down, but the price keeps going up. I mean, the overall cost keeps going up. It's incredibly expensive. And I said, but really, one of the major reasons is we just, we keep paying people for each admission, so you get more admissions, each procedure. All the incentives in healthcare financially are for more to be done, not necessarily for it to be done better. And I'm still not getting any kind of reaction from them until finally I said it'd be like if each of you were paid by the prayer. Right? And then there's this like incredibly awkward silence. Right? And my career flashes before my eyes. And at that moment there was this guy sitting across the table from me who, in my recollection, was wearing a cape. Okay. He may not have actually been wearing a cape. He had this thin face, and he leaned his hand, leaned across the table, put his hand on my hand, bowed his head slightly, and said, "Let us pray." Okay. So they understood that immediately, that payment incentives are really important. So in Maryland, we have this incredibly interesting tool called the Health Services Cost Review Commission, and it has been a special provision of the Social Security Act, which basically has allowed Maryland for 30 years to set a rate structure for each hospital. Each hospital has its own set of rates, and all payers, Medicare, Medicaid, Blue Cross, Kaiser, everyone pays those rates, essentially. And so it's for appendectomy at Hopkins, there's no cost shifting. It's all based on the structure that is set by state. We're the only state in the country that has that. Medicare participates, so that Medicare pays the Maryland rates in Maryland, not the Medicare rates in Maryland. So it's a big, big exception to national payment policy. So recently, there have been a number of interesting experiments with that. It was historically just done fee for service with rate setting, and there are a lot of benefits to this. It's one reason there are no public hospitals in Maryland, because there's a way to share uncompensated care costs through the system and medical education costs and other things, but it's still been predominantly fee for service. A few years ago, there was some experiments done, including giving rural hospitals global budgets. across all payers. So if you were a CEO, you basically knew your budget. And I'm not the payment expert in this, but this is the way I understand it, how they're able to do that. Let's say the budget's $100. The payment commission says to the CEO, your budget's going to be $100. If you have 5 admissions, we'll pay you $20 per admission. If you have 10 admissions, we'll pay you $10 per admission. You get to charge $10 per admission. If you have 20 admissions, you get to charge $5 per admission. So there's no reward for additional value. In fact, they can invest. In addition, they did a major, so there were about 10 hospitals that went to that, global budgets in Maryland 3 years ago. And then almost all the other hospitals went to a readmission type of bundle, which the way I think about it, and again, the little asterisk there are a lot of details, is okay, last year you had $100 in readmissions. We're going to give you $100, and you're going to pay for all your patients' readmissions. So if you can lower that, you're going to keep the difference. So that has led to a very different way of thinking about hospital finance. At the same time, it turns out that that special deal that Maryland gets under the Social Security Act was running out of steam. There's some conditions that were put on that by CMS. So we either were going to lose that, our system, or we were going to have to renegotiate it with CMS. So we had 18 months of negotiations with CMS. And in the end, we have a new agreement with CMS, which basically preserves the all-payer system, but says that our focus now will be on improving quality and reducing overall aggregate costs. And Maryland has committed all-payer to limiting the growth in hospital costs, inpatient and outpatient, to the smoothed average of state GSP, with a certain guaranteed cost trend for Medicare, and bring our readmissions down to the national average and have a significant reduction in hospital-preventable infections. And over the course of the next few years, to design a way to expand that for all costs, not just hospital costs. So there's a paper in the New England Journal that goes into some more detail about that. But it's basically, how are we going to succeed? We have committed as part of this to transition essentially all hospital payment for all payers out of fee-for-service, at least 80% over the next five years. So those types of interventions. What does it look like? And I'll tell you that I am very involved in the insurance exchange, and reporters always call me about the insurance exchange, and I sometimes try to change the topic. And one of the ways I change the topic is to talk about this, and I try to get reporters to go out to Cumberland in Western Maryland, where one of these global budget hospitals is. And you go in, and it is like the anti-gravity zone in healthcare. Like, it's the quietest hospital you walk into. It's like 2/3 filled. You go to the ER, they have here's the person who's going to meet specially with every person to make sure they're totally tucked in and they're not going to come back to the ER. They send their own nurses to nursing homes repeatedly to prevent readmissions. And the CEO, who's been the CEO through the transition, says it's a total culture change. It's like we have signs up that say, we hope we never see you again. This isn't the hospital that has only 2-minute wait time, for an ER visit on the highway. They're very focused. There's literally a bridge to the public health department, which is right nearby, and it's a well-trod bridge now, and they do a bunch of things together. I eventually did get, let's see if I can find it, a New York Times reporter to go out there, and he wrote a terrific article about some of the experiences that they have at that hospital. The last thing I'd say in terms, and so what does this mean? It means that there's a real incentive now to think about population-based health. We use data for population-based health. Now, particularly, and we're seeing a lot of that in these hospitals that have gotten a head start. I met with the CEOs of those hospitals, and they said, Josh, we're just amazed when we look at our ER numbers, how many people have behavioral health issues. We're really looking at that, and what can we do? I mean, it's to have hospital CEOs asking that question is amazing. We have one hospital that took over the school health program in Frederick and Hagerstown, and I asked the CEO, why did you do that? And he said, well, we looked at our ER data. We have so many kids coming in for asthma. We figure we can run the school health program, break even, and make all the money by reducing, hospital admissions and integrate our data system. So as these payment systems emerge, there are just all sorts of different opportunities that come up within clinical care. And so I think that's very positive. We're doing a lot to try to align people with that. approach, and I think particularly it's going to be good for the HIE because that becomes a critical tool. Hospitals can figure out their readmissions the moment they happen, rather than have to wait for some report and see what actually happened. The last very positive thing is I think that there's a lot of, the federal government is really trying to align to these types of efforts. CDC is working more closely with CMS than ever before, I think, and particularly CMMI is really investing in states' abilities to do innovative things with data, with population health outcomes in the sense that I'm using. Let me briefly focus on some challenges and then I'll stop. The biggest challenge, relates to the underlying lack of organization in the healthcare system and the fact that there's so many different players. Even though we have a degree of organization that other states have with our hospital system, we don't with respect to everything else. We have multiple everything, and that leads everyone to think that they have the secret sauce. Everyone thinks they have the secret sauce, and they don't want to pay for anything twice. And if I had $1 for every time I heard secret sauce or paid for it twice, then that's like half of my discussions about this because, well, why are you doing case management when, why does the clinic want to do case management when the payer wants to do case management? And you just have, there should be like, it reminded me actually of my time at FDA when we did a listening session on food regulations, and one of the people came out and said, I'm a small food manufacturer, and on Monday, I get the county inspection. Tuesday, I get a different inspection from the state. And Wednesday, it's the federal inspection. And it's all the same person in my county. There's only one guy. And he just comes back with a different checklist. And does that make sense to you? There's so many sometimes overlapping things. And most of it is sort of in the telephonic case management and not that impressive. And I also think that within that, there's very little appreciation for the types of tools that public health can bring that are completely separate from the types of tools that are at the disposal of even a clinic or a carrier. And I would also say that the lack of organization is not limited to the private sector. The public sector, there's multiple data sets within the federal government, very hard sometimes to get data, weird rules about what data can be shared, even within states, even within Maryland. We've got discrete data sources that are very aligned to specific purposes that can be very, very hard to integrate, even though there's can be such a strong rationale for it. I think we've been successful with respect to really building on the platform of our health information exchange, but some of our other databases we have not been nearly as successful with. I also think that one of the challenges is that people assume they understand that like, I totally agree, and I actually quote Farzad on the idea that these health systems with new financial incentives can cheat by partnering with public health. It's totally true. But everybody's first, I think, instinct is to try to recapitulate it completely within their own walls. So if it's a home care thing, the hospital will have a home care subsidiary, and if it's public health, they'll figure out how to do that, and there's a whole range of jobs popping up around that. And I think that there's a danger both on the, frankly, the healthcare side and the public health side, if people can't look across and to integrate it. And my feeling, and the last point I would make is that, well, on this, is that it's just as difficult on the public health side. And a lot of the discussions I have on the public health side are that we just can't be in our own silo anymore. Even if we have an intervention that is going to be cost effective, we've got to be able to engage and prove, not just prove the value, but be a partner to health systems that suddenly really do need to produce overall health outcomes. The last thing is, in terms of challenges, I think when it comes to health IT, and I am on the HIT policy committee, as you heard, I give myself points now because I can actually follow a sentence from start to finish. I went to my first couple meetings, I literally couldn't follow any sentence everybody spoke. I mean, like, I would be like, I'm gonna get this one, and then like, boom, at the end. It reminded me of when I lived in Central America and people were telling jokes, and I got it, and everybody would laugh. And I was like, I don't understand. So now I can more or less follow along, but I'm a little bit of the Sesame Street, which one doesn't belong, because I'm always like, can we talk about like examples where this is impacting health? And recently we had a meeting where it's about, okay, we're now going to do meaningful use standards for long-term care and especially behavioral health. And it like immediately just jumped to just this blizzard of acronyms and this, that, and the other. And I asked the question that Farzad just posed, which is, Why? What are we going to try to accomplish? Is it overdoses? Is it, readmissions? Is it, tell me, what is it? And it was like, silence. I mean, at least from my perspective, it's just, it would help to know what we're actually trying to accomplish in health to be able to do these things. And I think that it's important in any of the IT development or where things are going to really be able to think about health. I have no problem with saying, let's talk about the health of a non-geographic population, but also to keep an eye on the geographic population. And let me just suggest a couple things. One of them that we've been working on is we have tried to work with carriers and others to think about their data, because even though we have very good hospital data, and we'll get soon maps on where preventable hospitalizations are, we don't have the primary care side. There's certain things we don't have, and we're starting to work with people who will have that data. We have a project with one of our managed care organizations where they're telling us exactly which part of the state they see people who are more likely to go to the hospital for a URI by rate. And sure enough, there's a really good, there's a lot going on there that we can really be helpful with the primary care system. And we said to them, look, here's the value to you. You give us that data, and we'll bring the public health department, and then you'll tell us whether it works. So there's a whole local public health effort around that specific thing. I was talking to Jessica from Epic last night at dinner, and we were talking about the fact that clinical EHRs tend to produce reports for the clinics. But if there were an adequate partnership between the public health authority, the clinicians, and the companies, then you could actually pull that data and map it geographically across different clinical settings. And so if you knew, it's one thing to say that your colonoscopy rates are X, but if you knew that this was the part of the state where nobody ever gets a colonoscopy, there's a different type of tool you could bring to that. And the public health department could do that, and then you could see whether it works. And I think there's so much potential for that kind of thing, and to evaluate it rapidly if you were to have the data and have that commitment to do that. So I think there are ways of overcoming these things, even though there's a disorganized healthcare system in some ways. But I think that is part of the challenge. So I will basically stop there. The last question was looking to the future. Obviously, I think geographic health outcomes have got to be the bottom line. This is what we align our compasses to. Everything else, in my mind, is a means to that end. I think that making data and health outcomes integral to payment models is very important. I'm a big fan of matching grants for everybody. If you're going to give a grant in this area, make it a matching grant to one of the new emerging financial incentives to pull people a little bit out of their shell, to do something a little bit differently, and to put some of their own skin in the game so that if it works, then they will be more likely to invest in it later. And finally, I think that there's a tremendous potential value for public health. I would say 3/4 of my efforts is with the public health field, trying to get them to realize it and not just, be disappointed about what's happening to their categorical grants, that there's this incredible opportunity. And I think, but not only for health systems, but for providers of health IT and others to make that partnership. So I hope this is helpful, and thanks for having me.
Two or three quick questions that people would like to ask. I'm sure you can go for it.
Sure.
There's a new type of data that's arising, which is really patient-generated data. What do you see us doing with all of that, whether it's biometrics, lifestyle, behavioral? How does that get integrated into the future?
So I think that that's right, and linked with that are sort of these devices and mobile that are springing up all over the place. I think that there are two kinds of uses. So one is for clinical care, and they'll have to prove their value in different ways in clinical care. But the other is the potential public health benefit of that. The one that I think is just, very, very interesting, for example, is the, GIS inhaler, rescue inhaler, where every time it's used, it sends a signal and you can get a real map of actually where rescue medications are being used. That would be one, example. I think that there's probably going to be a lot of innovation in that area. And then what's going to matter is whether there's evidence that it's actually helping clinical outcomes, and maybe secondarily, if there's ways to think about linking that to some of the community public health outcomes, you'd be able to get investment in that through a different track. In Maryland, we're talking very seriously about setting aside some of the Invest Maryland funding. There's like a public biotech investment fund for small grants to device companies that could help us produce value through our waiver, our hospital payment system, and to think about different devices that may be able to be helpful. I have a good friend who has worked very much on, he's a neurologist, on goggles that you wear that measure eye movements in dizzy patients and can better predict whether a stroke is underway than an MRI. And so, you know, if the financial incentives are one way, maybe everybody wants just to do the MRI. But if the hospital, you know, could actually think about it differently, then there's just a potential completely different market for these kind of devices that can improve outcomes and lower costs. So we would, in Maryland, we're going to try to spur more innovation in that area. And I think from my perspective at FDA, I think that there's a big interest in the Device Center in identifying devices that aren't, you know, maybe just about generating data, but really can have a link to better health outcomes. That I think that hopefully there'll be quicker approval paths and other things like that. Yeah.
You mentioned, first of all, thanks very much for the presentation. You mentioned some of the problems with siloed databases and siloed public health systems. Which prevent, you know, inhibit not only efficient public health performance, but sometimes even prevent categorical disease programs from achieving the full measure of their success. What are some of the solutions to that?
You know, I think that it's challenging because some of the barriers that are in place are barriers that have been built for sort of historical reasons, particularly around certain privacy issues. So we've been able to do a lot through the Health Information Exchange because it's emerged and we've been able to have a dialogue about it as a new tool, whereas other systems have been around for a while and you're literally dealing with state law or federal law in terms of sharing of data. You know, I think that I've learned that there's kind of a very interesting history around the single identifier in the United States. You know, people don't want to say it out loud, you know, because something, you know, but it's that alone has made things so much harder to pull databases together. So
even the funding that comes vertically into the local health department is sort of impediment. So
it's a huge impediment, yeah, and I think, and I'll be honest with you, it is not a lock we've completely picked. I mean, we've been able to add things to a common database, but where we have existing databases and they've got all of their local people and laws and everything behind it, some of those have proved kind of impenetrable to us right now. So, you know, it's definitely a major challenge, and you know, I think we've seen some progress, but I cannot completely squarely look Jonathan Weiner in the eye yet. You know, I'm waiting for that point where we've got it all together and it can be used for its full, you know, potential. But we've been trying, and the Affordable Care Act has given us some extra funding sources to strengthen and bring things together, but it is definitely the slowest thing. I was telling a story last night. Our governor, Martin O'Malley, is incredibly interested in real-time data and getting common platforms. And he's got now all the first responders on the same platform, and he's got cameras on every snowplow, you know, so he can see exactly what's going on. And he collects data from Twitter from people, and he's, you know, for public health emergencies, we have all these different, you know, programs, and we had this big heat spell here. And we were, you know, all over the data from all our different sources, and we were able to generate a report the next morning, not only of the ER visits for hyperthermia, but the ambulance calls for hyperthermia, and we were able to map them and send people out, you know, the next morning to see how everybody was doing and to check things out. And I told him about it. We were at the National Governors Association, and he looked at me and he said, like, that is so embarrassing that you have to wait till the next morning, John. And not to actually say that publicly, you know. And Ali Khan from the CDC was there, who, you know, and he was saying, you know, Governor, I just want you to know you're the only state I've ever heard of doing this. This is so exciting that you're able to use all these different systems for a public health response. And the governor just looked at him and afterwards and was like, you know, it is so embarrassing. We have to wait until the next day. I mean, it's just, so there's even, you know, we have a lot of political leadership. There's a lot that we're able to do, but It is an enormous challenge despite all that.
So I think we've run out of time, but join me in